Welcome all for today's class. Today we'll start with the physiology module, and today's topic is the physiological changes in pregnancy. This topic is very important because there will always be 3 to 4 SBS from this particular topic. Okay, so listen to the talk very carefully till the end. So basically, pregnancy causes progressive anatomical, physiological, and biochemical changes. These changes involve the genital organs as well as other body systems. The purpose of these changes is mainly the maternal adaptation to the fetal demands. What is the clinical importance? So we should be able to differentiate these physiological changes from the pathological changes. Okay, so we will see the changes in the genital organs as well as other body systems. So in the genital organs, external genitalia and the internal genitalia we are going to discuss. So in the vulva will become the edematous, more vascular. The superficial varicosities will be there. That is quite common, especially in multipara. Labia minora will be pigmented and hypertrophied. There are changes which are happening in the vagina also. The structural changes will be the wall of the vagina will become hypertrophied, edematous, highly vascular. They will look bluish in color. That is the Jack-Weimer sign. Okay, so you should remember this sign. That is the Jack-Weimer sign is the bluish discoloration of the vagina. There is increased length of the anterior vaginal wall. Okay, there are vaginal secretions which are copious in nature. They are thin, curdy white, and basically they contain bacteria as well as exfoliated cells. It is acidic in nature. The pH is around 3.5 to 6, and it contains basically the lactic acid. The glycogen is broken down into the lactic acid from the lactobacilli, and that is why the pH becomes acidic. And this acidic pH is important for prevention of pathogenic growth. Okay, so the pH which is acidic 3.5 to 6, that is also SBA here. Okay, so please remember this. Then what about the cytology of the vaginal secretion? There is a presence of navicular cells. These are clustered cells, and you get abundant lactobacilli. Okay, so this is what is the vaginal cytology. Then coming to the uterus, what happens in the uterus during the pregnancy? The size and capacity changes. In non-pregnant uterus, the weight of the uterus is just 60 gram, which will become around 1000 gram. That is almost 1 kg. 900 to 1000 gram is the weight of the uterus. Then length, which is normally 7.5 centimeter, it will become 35 centimeter. And capacity of the uterine cavity, which is around hardly 5 to 10 ml, will become more than 500 up to 1000 times. There is an increase in the capacity. Okay, then coming to the why the uterus enlarges. So what exactly happens? So there are changes in the muscles. There is a hypertrophy as well as hyperplasia, and this is prominent till 12 weeks of gestation, which happens under the influence of estrogen and progesterone. So under the influence of estrogen, progesterone, up to 12 weeks, there is a hypertrophy and hyperplasia. But after that, there is mainly the stretching. Okay, especially after 20 weeks due to the fetus. The wall will become thin, around 1.5 centimeter at term. It will also become soft and elastic. Okay, and there is a very typical arrangement of the muscle fibers of the uterus. It has got 3-layer arrangement. There is an outer layer which is longitudinal, then inner layer which is circular, and the intermediate layer which is in a crisscrossing manner. So this outer longitudinal layer will cover the fundus. Then inner circular layer will cover mainly the sphincter at the os as well as tubes, and the intermediate layer which is in a crisscross manner that acts as a living ligature which controls the bleeding. So this is the 3-layer arrangement. Okay, near around fundus you will get these longitudinal fibers, and then you have these middle fibers which are in a crisscross manner. They are mesh-like fibers, and the blood vessels will pass through this, and that helps in the control of the bleeding. And you have inner circular layer which is mainly around this cervix as well as in the tubes. Okay, at the opening of the tubes. Then there are changes which are happening in the vascular changes. Okay, so the uterine artery, the diameter is doubled. The blood flow is increased around 8 times. This is as early as by 20 weeks. So 8 times increase in the blood flow. Arteries which are spiral arteries, they will become straightened in the latter period. There are veins which are dilated and the valveless. Okay, lymphatics are increased, most marked at the placental site. So what about the shape of the uterus? In early pregnancy, it is pyriform in shape. By around 12 weeks, it is globular in shape. By around 28 weeks, it is ovoid in shape. After 36 weeks, it is around spherical in shape. Okay. The position of the uterus also changes. Okay. Normally, we know that uterus is anteverted and antiflex. So in early pregnancy, there is increased anteversion that causes increased frequency of maturation. Later on, it becomes erect. Okay, so near term in multipara, it is anteverted, while in primary gravida, it is aligned with the spine. Uterus is also rotated slightly, that is called as dextrorotation. It is the rotation towards right due to the rectosigmoid which is present on the left. There is a slight dextrorotation. Okay, while cervix will go towards left, that is the levorotation. Then there are certain peritoneal changes. The ligaments of the uterus, they will rise above the level of the pelvic brim. There is a pouch of Douglas which will become more deep, and some uterine areas will be lacking the peritoneal covering. Okay. Then coming to the contractions of the uterus, what we call as physiological contractions are the Braxton-Hicks contractions. These are irregular, painless contractions. They will begin early in the pregnancy. However, their frequency is initially it is infrequent, but it increases near around term. But most peculiarity is that they are not associated with the cervical dilatation. They are not felt by the patient, and there is no increase in the uterine pressure, intrauterine pressure. The pressure is less than 8 millimeters of mercury. Okay, so there is a temporary decrease in the blood flow because of these contractions, and it may lead to the fetal bradycardia. Okay. So these also Braxton Hicks contractions you should remember. So uterus we have seen. Now we'll talk about the isthmus. Isthmus is the part which is joining or which is present between the cervix and the body of the uterus. So this isthmus also shows changes. In the first trimester, there is a hypertrophy and elongation, almost 3 times elongation of this particular. See, this is the part is the isthmus between the body of the uterus and the cervix. This part at the junction is the isthmus. There is almost 3 times elongation. There is a hypertrophy and elongation. Okay, there is also softening of this particular part. After 12 weeks, it starts becoming the part of the uterine cavity. Okay, so at 8 weeks, this is smaller in size. At around 12 weeks, it is increased in size. Not only that, from 12 weeks onwards, from the upper end, it starts opening up, and this by around 16 weeks, it becomes the completely the part of the body of the uterus. Okay. So what is the function of this? It acts as a sphincter. So it will retain the fetus. Then failure will lead to the mid-trimester abortion, and that is the basis for the cervical encerclage operation. Now let's talk about the cervix. So cervix also shows the structural changes. There is a hypertrophy and hyperplasia, increased vascularity that shows the bluish color, and there is a fluid accumulation causing softening of the cervix, and that is the Goodell sign. This appears as early as around 6 weeks. Okay, so we have seen Jack-Weber sign is in the vagina, that is the bluish discoloration of the vagina, while Goodell sign is in the cervix, and that is the softening of the cervix because of the accumulation of the fluid. As early as 6 weeks, you will get this particular sign. Okay, next there are epithelial changes. Okay, so these epithelial changes which happen in the cervix, there is a proliferation of the endocervical mucosa. We know that the endocervix is lined by the columnar epithelium. So there is a proliferation of the endocervical mucosa that leads to the ectopy or erosion. Okay, and this mimics the CIN, but it is actually benign. Okay, that is why we cannot comment on this CIN changes in the pregnancy. We should wait for these changes to regress. Okay. So, this is the columnar epithelium. It will come out outside, and it will be the ectopy. Okay, you will get ectopy. Not only that, the cervix will have secretion which is thick, and this secretion is also increased. So these changes which are happening in the cervix, they are hormone induced, but they will regress postpartum. Okay, so cervical secretion, it will become copious and thick. It forms a sort of plug. Okay, it is under the influence of the hormone progesterone. It contains the immunoglobulins and cytokine, and it forms the mucus plug. Okay, then there are anatomical changes which are happening in the cervix. The length of the cervix is remained unchanged, but the bulk of the cervix increases. Okay, so direction is posterior, and near term it will align with the vagina. Okay, so in near term, in primary gravida, there is an effacement, while in multigravida, apart from effacement, rather than effacement, there is a slight dilatation. Okay. So now coming to the fallopian tubes. The fallopian tubes will become vertical and congested. There are changes in the muscle which shows hypertrophy. Epithelium will also flatten. Decidual reaction is present and length is slightly increased. Okay. Now what happens in the ovary? In the ovary, there will be presence of corpus luteum. Okay. After the fertilization, this corpus luteum will persist for a couple of weeks. The peak size of the corpus luteum is around 8 weeks, which is around 2.5 centimeter. Initially, it will appear orange, then it becomes yellow, and then it becomes pale. Okay. So it will regress as the SCG level will decrease, and there is a complete degeneration by around 12 weeks. Later on, it may get calcified also. Okay. What is the role of this corpus luteum? It secretes the estrogen and progesterone and maintains the pregnancy. It also inhibits the ovulation, and that is why the menstrual cycle stops. Okay. So there are additional changes. So decidual reaction is seen on the surface of the ovary. There is a luteinization of the follicles, and possible leukemia of the pregnancy may be seen. Okay. So just in the summary, what are the changes in the genital, external and internal genital organs? Vulva will become edematous, pigmented, varicosities will be present. Vagina will be bluish in color, acidic pH and increased secretions. Uterus, there is a massive enlargement and increased vascularity. Isthmus will soften and forms the lower uterine segment. Then cervix becomes soft and it shows the Goodell sign. There is a presence of mucus plug. Tubes become vertical and hypertrophied. Ovaries will show the corpus luteum, which is active, and the ovulation will stop. Okay, so these are the changes in the genital organs. Now coming to the changes in the breast. Okay, more prominent in the primary gravida, the breast changes, less obvious in the multipara. Okay, uh, they already had a previous lactation, so the changes are less prominent in the multiparas. Then size and structural changes, early increase in the breast size is seen, and this is mainly because of the estrogen and progesterone hormone. Under the influence of estrogen, the duct will proliferate. This you should remember. What is the effect on the duct and what is the effect on the alveoli? Okay, so the duct will proliferate under the influence of estrogen, and alveoli growth is under the influence of both estrogen as well as progesterone. Okay, so there are additional changes which are happening in the connective tissue, which shows the hypertrophy. Myoepithelial cells will become prominent. There is increased vascularity. So there is a visible bluish veins and enlargement of the axillary tail, and skin stretching will lead to the striae formation on the breast. Okay. Now, what are the changes which are happening in the nipple and areola? Nipple will be enlarged, erectile, and pigmented, while areola will be darkened. Then there are Montgomery's tubercles. These are 5 to 15 enlarged sebaceous glands. They provide the lubrication and protection. That is the function of these particular Montgomery's tubercles or the gland, sebaceous gland. There is a secondary areola which appears in the second trimester. Okay, so the areola is a darkened area around the nipple. Okay, there is a secondary areola which appears in the second trimester. Then secretion from the breast, there, which is called as colostrum. So by around 12 weeks, you get some sticky secretion. Around 16 weeks, it becomes thick and yellow, and in late pregnancy, it is easily expressible. Okay, so presence of secretion is also one of the important sign of the pregnancy. So secretion in non-lactating women is a pregnancy indicator. Okay. So there are changes which are happening in the skin also. So what are the cutaneous changes? There is a pigmentation. So in the face also, what you see is a chloasma gravidarum. That is the mask of the pregnancy. It will patchy, diffuse pigmentation. It disappears after the delivery. That is postpartum. It will disappear. Then in the abdomen, these also you should remember: Linea nigra, then Linea alba, Striae gravidarum. These questions they can ask you on the image also. Okay. So Linea nigra, that is the midline dark pigmentation extending from xiphisternum to the pubic symphysis. Cause is a melanocyte stimulating hormone and also estrogen and progesterone influence. Okay. Then there are stria gravidarum. This stria gravidarum, they are present over the abdomen, thighs, breast, and it is a linearly depressed marks. Initially, they are pink in color, but later on they will become white, which are also called as striae albicans. and it happens mainly because of the stretching of the skin, plus there is a effect of the aldosterone. Increased levels of the aldosterone are also responsible. Prevention is mainly by controlling the weight gain and skin lubrication. Okay. There are other skin changes such as spider angioma, Palmer erythema. This is due to the high estrogen level. Mild hirsutism, which is lost after the delivery. Okay, so these are the changes in the skin. Then what is the about the weight gain? This also you should remember what is the normal weight gain in the pregnancy. So early pregnancy, there may be little weight loss. There may or may not be weight gain in the early pregnancy. This is mainly because of the nausea and vomiting. While in later in pregnancy, there is a progressive weight gain. While last weeks, the weight stabilizes. Okay. So this chart shows the weight gain during the pregnancy. In the first trimester, there is a hardly 1 kg weight gain. Okay. Sometimes there may be little weight loss also. In second trimester, around 5 kg, and third trimester, around 5 kg. Around 11 kg is the total weight gain. And now how this weight is distributed in various organs. So it is also further distributed into reproductive components and the maternal components. So reproductive components such as fetus will weigh around 3.3 kg, placenta around 0.6 kg, liquor around 0.8 kg, uterus is around 0.9 kg, breast around 400 gram or 0.4 kg. Okay. Normally here they are asking about the fetus is to placental weight ratio. Okay. So normally placental weight is around 500 to 600 gram or 400 to 600 gram, and the baby weight is around 300. So 1:5 is the placental fetus to placental ratio. Okay. Then maternal components, blood volume is increased, which will contribute around 1.3 kg. Extracellular fluid is increased, which will contribute around 1.2 kg. Fat and protein weight total is around 3.5 kg. So that is how the total weight gain is seen during the pregnancy. Then what is the clinical importance of weight monitoring? Rapid weight gain may be the indicator of preeclampsia, onset of preeclampsia. So normally what we expect up to 0.5 kg per week. If it is more than 0.5 kg per week, we may think about the preeclampsia. If it is a static or falling weight, then it will suggest the IUGR, fetal death, etc. Okay. Then weight gain based on the BMI, because normally though we mention around 11 kg on an average, that is the person who is having the normal BMI. So if the BMI is normal, around 11 to 16 kg weight gain is normal. If the patient is obese category, the BMI is in the obese category, then the expected weight gain is 7 kg or less. If the patient is less than 19 BMI, then up to 18 kg weight gain is expected. Then coming to the changes in the electrolyte and the fluid changes. So there is a electrolyte retention. Sodium will be around 1000 milliequivalents, potassium around 10 gram, and chlorides are also increased. What is the cause of sodium retention? It is increased because of the estrogen and progesterone level, also because of the aldosterone, because of the activation of the renin, angiotensin, aldosterone system. Then because of the ADH also to some extent. Then there is a water retention. Total water retained is around 6.5 liters. The distribution of the water is in the fetus, placenta, and liquor, that totally will form around 3.5 liters of the water. Okay. There is a edema in the pregnancy, commonly seen in the legs. This is due to one, because of the decrease in the colloid osmotic pressure, and because of the increased venous pressure. Okay, this we will see subsequently in the discussion. There is a decrease in the colloid osmotic pressure also, and increase in the venous pressure also, especially the lower limb pressure. Okay, around 100 centimeters of water, that much is increase in the standing position. Okay, that also we will see subsequently. Then body water metabolism, what happens? Pregnancy is a hypervolumic state. There is a retention of sodium around 900 milliequivalents, potassium around 300 milliequivalents, and there is a retention of the water. Okay. Then what is the hormonal regulation on this water and the electrolyte balance? Estrogen and progesterone will lead to the increased sodium retention. Renin, angiotensin, aldosterone system activation will lead to the increased aldosterone. The ADH, okay, also called as AVP, that is responsible for the water balance, and nitrouretic peptides, they will oppose the renin, angiotensin, aldosterone system. there is a osmoregulation during the pregnancy. There is a decrease in the plasma osmolality and decreased sodium level. Okay, so the blood volume increases, plasma volume increases, though the sodium level is increased, but there is a disproportionate increase of the plasma. So there will be sodium level will be decreased. Not only that, the plasma volume is increased, so plasma osmolality will be reduced. So what happens? There is a resetting of the thirst schedule threshold as well as ADH secretion threshold. Okay, and as far as ADH dynamics are concerned, the production is increased, but the plasma level remains unchanged. Okay, so ADH production is increased, but the plasma level will remain unchanged. The reason is because of there is an increased breakdown by the vasopressinase. So the vasopressinase is the enzyme which is produced from the placenta. So even if the ADH levels are increased, the breakdown is also increased. That is why the plasma level remains unchanged. Okay, in spite of production being increased. Then early pregnancy, there is increased thirst and mild polyuria. Fluid balance will be maintained at a new steady state. Okay. So what we have seen up till now, the breast will show enlargement, colostrum will be there, and the pigmentation is noted. Then skin will show chloasma, linea nigra, and striae gravidarum. Weight average is around 11 kg over a period of 9 months. Electrolytes, there is a sodium and water retention and water metabolism. There is a hypervolemia and decreased osmolality. Okay.